Good morning, and thank you very much all again for joining. Thank you, Mark. Thank you, Florika, for being here. So we're here on a Saturday morning. It's Valentine's Day. I'm guessing you're not here because you find that the 100 Days mission is a romantic ideal. I'm guessing that you're actually here because we have quite a lot of work to be done to make the 100 Days mission an operational reality, and this is a large part of the work that we do at CEPI with yourselves at the Gates Foundation, with HERA, with many of the other partners in the room. So this is really a conversation around how we bring together the stakeholders. What are the challenges for us as a community? What are some of the opportunities that we see against the very, very dynamic backdrop that we're operating in? So Florika, I'm going to turn to you first. You're Director General at HERA. HERA was very much created with a view of designing, developing medical countermeasures for Europe. And as you look around at this convergence of dialogue around security, at the scientific progress that's happening, at the geopolitical landscape shift, tell us a little bit around the steps that you're taking at HERA to progress this work, and tell us a little bit about how the regional view for Europe fits in with the international work you do with CEPI.
Well, that's a lot of questions in one. I will try. But let me try perhaps by starting that we were enormously inspired by your 100-day mission. And actually, you set the benchmark. You set the benchmark. It might have been aspirational, but at the time, we were taking it very serious. So we were setting up not only prevention preparedness measures, but really new structures now in order to be able to reduce the time for the development of a new vaccine or whatever type of medical countermeasures we would need. So we were, for instance, just as an example, we have now the network of laboratories and excellence centers of research, the durable network. We have a vaccines network hub. They can really try to look immediately when a new pathogen would occur. What would it be? Identify. The whole idea is to try to get a first prototype of an antidote ready as quickly as possible. And then with the durable network, with the vaccines hub, with clinical trials that they can facilitate, and what we have set up as a industrial network for production and scaling up, that then we could reduce it in case of a disease X. So just to say that it was very inspiring for us. I know that you are launching now a new strategy. We have launched our strategy last year, and I think it's very good to have a policy goal. We might not have said specifically biosecurity, but actually when you look at our MCM strategy, a large part of it is CBRN and armed conflict and mass casualties. That's one of our 4 priority threats. Like you, we go on viral families. So pandemics still very big for us, AMR very big for us, and of course vector-borne diseases, all that is linked to climate change and biodiversity degradation and loss. But then comes this 4th category, and that is one where I was joking when I saw General Everson. We are always now on the same panels. Yeah, but think about that. A year ago, we might not have been able to make that joke. That means already we are moving closer. We have structural dialogues together now. We are understanding that we really have to, at least for that category of threats, have to work differently together. We are not there, but we should be aligning much more from the entire pipeline, whether it's surveillance and detection to even how you would call innovation and research, and then potentially pooled procurement, and so on and so on. Jane very eloquently now reminded us on smallpox. We just issued last year, end of last year, we had a big joint procurement for our member states on smallpox, on mpox. Mpox and smallpox, same. And in that call, Also, Ministry of Defense ordered the Mpox vaccine for us, which is already a change. And that's probably what we will be going to do. I mean, we did that when we had the Mpox outbreak in Africa, but it also has a counterpart where it happens to be, with that at least, vaccine, that it could also be helpful for strengthening our deterrence or also our resilience in certain situations. Now, I have brought my iPad because there are one things which I really can't pronounce really well, is what we are doing right now on biosecurity. There's one thing also perhaps I have to say, which is not so known. When HERA was created, we already had the mandate for CBRN countermeasures set up. And we have set up a stockpile. And that stockpile exists since several years. I mean, located in different sites in Europe, maintained. But of course, now we have to replenish this stockpile. And that contains specifically also CBRN antidotes, but also other things, PPEs, everything we would need also in a pandemic. And then, as I said, we combine that with this reservation contracts that we have, with joint procurement, with the constant output of calls for innovative research, and so on and so on. So we really scan that horizon, but we also go really in a pipeline approach. But on biosecurity, apart from now having to look at our stockpiles, we also now have, and that's why I need really my iPad, because it's a mouthful. We have an ongoing biosecurity project of 24 million on pathogen agnostic clinical metagenomic sequencing, so as to ensure an early detection, whatever it might be. It might be a natural one, it might be a non-natural one, it might be the accidental, the naturally, or the intentionally released one, which, by the way, also in the wastewater surveillance system that we have pushed out since the last 5 years in Europe and now go global with the big airports as super sites, we also have a protocol that checks on specific pathogens, but also on those that are not known. So again, you get broader. But on the biosecurity, so we have this pathogen agnostic clinical metagenomic sequencing. We also have, of course, ongoing now the development of the next generation reusable respiratory or other PPP equipments for 8 million. And we have just launched funding calls for specific CBRN medicinal products and diagnostics and so on. It's a budget of 20 million. Why I'm saying that, I just want to say we are not neglecting AMR. We are in our funding and research, in our partnership. We are not neglecting the pandemic preparedness. We are not neglecting the vector-borne disease. On the contrary, we're very much going on that as well, because it's a really big threat for Europe. Because if it becomes endemic, we have really big issues. But CBRN is really part of our portfolio now. And I'm glad that we are here, and that in the context of civil-military cooperation, this becomes something where an MCM is a dual-use component. So whether it is a soldier or it is a civilian, they might and hopefully will be saved by the same MCM, by the medical counterpart, or the same vaccine. So it is in mutual interest. And as Jane was very eloquently saying, if we would have such a situation, a mass casualty, a hybrid attack, a limited armed conflict, I mean, the strain on our public health system will be enormous. And of course, we are discussing how to, do the medevac evacuation. General Everson will say that much more. But you also need to have, because of supply chain issues, because of surge capacity limitations in industry, and so on, you need to be ready before. So we are part of that, like you. But you have, again, inspiring us, you do with Gavi a partnership on biosecurity. And both of you are very, very strong partners in the global health architecture.
Great. And thank you so much, Florika. And I think we'll come back and build on a couple of themes and how the conversation indeed, I think, is progressing year to year. So, Mark, I'm going to turn over to you next. At the Gates Foundation, very, very strong priority in terms of combating infectious disease and health equity. So describe a little bit from your perspective as you think about the scientific capabilities that need to be developed and the role that CEPI can help build in this space.
Yeah, so thank you, and thank you, Jane, and thank you everyone for being here. The Gates Foundation, we were founded in 2000 with a vision to see where we could make the greatest impact for human improvement, and found very early on that that area of greatest impact and greatest need and greatest inequity was global health, and particularly deadly infectious diseases that disproportionately affect the poorest, both infectious diseases like pneumonia or rotavirus that need childhood vaccines, but the big infectious diseases of HIV, TB, malaria, and of course existing diseases like polio, which still is not yet eradicated, even though it's down to a couple of dozen cases. And so we ended up developing a lot of expertise in terms of both the research and development, the innovation, looking for partnerships. We helped create the Gavi Vaccine Alliance, and Sonia is here, and Helen is the new chair. And we think that actually is a great platform as an example of an incredibly cost-effective, high-impact, highest impact in terms of the human impact, life-saved multilateral investment of the 21st century. The Global Fund to Fight AIDS, TB, and Malaria, similarly, crowding in philanthropic resources, governmental resources, others to find, in this case, not yet a vaccine for HIV. We hope a vaccine for TB. We have some in final trials coming through. We'll get results next year. And in malaria, some early vaccines that are having some success. But we have a wide variety of tools available to deal with these deadly diseases which affect millions of people. But to be honest, we never thought we'd be working in broader epidemic preparedness writ large, because we assumed that was just such a clear global public good that of course the world's governments would be taking care of making the necessary investments, that we were dealing with were perceived market failures that disproportionately affected the poorest, and which is why many rich countries and rich private companies were not putting in investments. And yet it became clear that there wasn't the case, that the world was not ready preparing for the next potential emerging pathogen. And so with other partners, including the Wellcome Trust, also in the room, and those, we were part of the earliest discussions with the first wave government to end up forming what became CEPI, because there was such a gap in the international architecture for an entity able to do initially the research capacity, but as it's evolved and as is now articulated in the CEPI 3.0 framework, looking across the research, the platforms, the manufacturing outputs, what is the ecosystem that's going to be needed to reach that 100-day threshold, or as Jane says, we want to be more ambitious than that 100 days. But the state secretary was being semi-humorous when he said, welcome to the most important panel at the Munich Security Conference, when many people are listening to Secretary Rubio. My fear is this is the most important panel. That the single highest risk for the largest number of people on the planet is a bio-risk. Particularly, as was alluded to now, the risk of bioweapons generated by AI is very, very real. So there's both the naturally generated pathogen and a maliciously generated pathogen, and that risk is only going to go up, not down. And so for relative resources, the ecosystem that's needed for the world to put in place requires a CEPI at the center. It also requires the kind of things that you just heard in terms of your appropriate surveillance networks that are deep and robust. It means accelerated regulatory pathways with national regulators and global regulators. We need that ecosystem put together, and really, it's a bargain. That the numbers that get thrown around the Munich Security Conference again is U.S. defense spending getting close to $1 trillion a year, European defense spending now getting close to 500 billion euros a year. the numbers we're talking about here for a $2.5 billion CEPI replenishment for, it's great that you're making those investments, but I was conscious they all had M's after them, not B's.
Yeah.
There's
also a big one for you.
And so that is actually a misallocation of global resources in a deep and fundamental way. And we think philanthropy can play some role, so absolutely, CEPI can count on us to remain strong and robust supporters. But we're doing it as much to try and leverage in the partnerships where we need government leadership, and exactly the way Jane cited up front, this cannot be done and left to traditional ODA or other pools of money, especially at a time those resources are simply shrinking rapidly. These are core public good resources that should be coming from military and research budgets across high-income countries who have the biggest capacity to do it, and especially, just being blunt, at a time when, let's say, US capacity is somewhat challenged in the current political environment relative to rebuild, which we hope will be rebuilt. I think there is an important leadership role and a need for institutions like HERA across Europe to be able to step in, and not to the gap, but to play a critical leading role. And from our purposes, we hope that that will be seen and expressed first and foremost in the CEPI replenishment, but actually in a much wider, more robust, ongoing global solidarity that is completely self-interested, our countries, and making the investments to ensure that we don't have something that gets into that scarier set of numbers of the trillions of economic energy and the millions of lives, and this could be easily in the hundreds of millions of lives, not the tens of millions of lives that Jane talked about.
Thanks. And you just said something which resonates, which is there is actually no contradiction between solidarity and self-interest when we think about fighting infectious diseases and epidemic and pandemic threats. And I want to link that back to what Dr. Plyer was saying in terms of taking matters into our own hands, which is also something you both have alluded to. I'd love to hear from each of you thinking about, as you've seen the work that CEPI has developed over time, as you look towards the next 5 years and the new strategy, what is maybe one thing that really strikes out as a strategic alignment or progress that's been made, and what is maybe one thing that is a really important bottleneck or challenge for us to address next?
Perhaps I could start with a very practical example. I just came back Tuesday, Wednesday from Senegal. And everybody in the room, in one way, is involved in the local manufacturing support that we are trying to put up in Senegal. I know that you had different views on whether or not we should go for local manufacturing. The European Union is very strong believer in that. But I was very heartened to see when I was in Senegal and seeing the Madiba and the Afro-Amaril facilities. You are in, WHO is in, you are in, we are in, Team Europe is in. So we are working together in setting into place capacities in countries that they can produce vaccines, which we might be needed as well, because it is bidirectional. It's not just like us selling there, it is also us buying from there. It should be a web of surveillance capacities, research capacities, production capacities, because COVID has told us boundaries. I mean, the disease might not be bound by boundaries, but regulations, export controls, whatever, creates boundaries. So it is safer to have an architecture that is, it is interdependent. I think that's also useful, because then we work together and we stay together, but it's also able to act for their regions or participants themselves. So I think there's a lot of alignment here. And you could go on many other issues where we have similar alignments. I think one of the big, ideological, perhaps, if I never use that word, ideas is also that we want to keep a open system, an open global architecture that aligns everybody here in this room, definitely Gavi, definitely CEPI, and also Gates and Wellcome Trust and us from European Union, because we are stronger if others are stronger. And that is a fundamental difference, I think, now with other players in the room. Not here in this room, elsewhere now.
Yeah, great. So thank you. Well, first, just to clarify, and on the manufacturing point specifically, we are as investors, co-investors in this case in the Institut Pasteur Dakar in Senegal. That our view on the manufacturing of both vaccines but also health products is that clearly you need to have global manufacturing distribution networks, but what you shouldn't be having is every single country trying to develop its own thing. You need to find platforms that are going to have financial viability. So actually, in the case of IPD, we were the original investors in helping them develop a yellow fever vaccine, which was the first vaccine in Africa that got World Health Organization pre-qualification. We have an investment which we recently did with BioVac in South Africa, which is working on new cholera vaccine, where there is a critical need and shortages of cholera vaccines right now. We've worked in multiple countries around helping ensure that there is mRNA available technology, actually drawing on European technology that comes from Belgium that sits now in countries like South Africa, but also Brazil and Indonesia and elsewhere. And so that is part of the ecosystem that needs to exist, that needs to be collectively funded, that's able to do that. And other products, that's vaccine manufacturing, but two of the most important investments we made during the COVID were actually advanced syringe manufacturing factories, one in Rwanda, one in Kenya, which now have a whole domestic, because that was one of the critical bottleneck shortages for the delivery of vaccines during the crisis. So what we're talking about, and these are good examples of what's the ecosystem that needs to exist for broader, epidemic preparedness and being able to ensure that the world is ready, including in those countries which did get marginalized or at least delayed in the distribution, notwithstanding the great efforts many in this room, including CEPI and Gavi and others made with the COVAX vaccine facility. But the reality is distribution of vaccines got to the global south much later than it got to the global north. And that is something, our 100-day vision is that there should be equitable distribution of whether it's vaccines, treatments, whatever response tools we have available as quickly as possible. And then to your specific question in the CEPI, bluntly, I think the best thing CEPI is doing right now is being able to build on the efficiencies and learnings of CEPI 1 and 2, which is thinking about platforms and thinking about those ecosystems. You have strong examples with reasons like Marburg and so on of how you actually respond directly with and in partnership with countries where those outbreaks are happening, being able to respond incredibly quickly and build in and tackle global networks. But the fundamental gating problem, to end where we started, is ensuring that you are fully resourced to be able to carry that out as a global public good. And so really urge for those who are in positions to both advocate, to drive, to provide financing. Again, we as philanthropy will actually step in and we will do our part, but we see our greatest role really is about our core mission in those big infectious diseases that still disproportionately affect the poorest. And so it's why our voice is here at Munich and in many other forums saying, CEPI 3.0 is truly, in terms of the world's potential best buys against future risk and impact, there's almost no better investment out there.
Great, thank you. I think that's a perfect place for us to wrap us up. So thank you, Mark, thank you, Florika, and to the Gates Foundation and Kira and the many partners in this room for your support, making the 100 Days mission not a romantic ideal, but an operational reality. Thank you very much.
Thank you.
Please now welcome Chair of the NATO Committee, Brigadier General Petter Iversen, for a conversation on National Security Report.